Opioids have a long record of use in medicine, even going beyond just what we consider to be traditional medicine these days. It's been, centuries and even longer, depending on what recorded history you're looking at. But the bottom line is, in modern traditional medicine, opioids have been used with success and with great failure, depending on how you look at it. I have to say that we are continuing to use them for treating chronic pain, intractable pain, that sort of thing. But you don't see that in dentistry. I think one of the things I make a hallmark of my lectures, which all people bring with them afterwards, is I believe that in dentistry we use opioids more to treat fear than to treat pain.
That's interesting. More to treat fear than pain. Welcome to another episode of the Irreplaceable Dental Team. If you're looking keenly, you'll see a handsome face that you've seen before. He is none other than my friend, Tom Viola. Tom, how are you today?
I am good, Heather Dawn. Thank you so much for having me. It's always a pleasure working with you. And you are the greatest, most patient person I know who was able to track me down and keep me in one place long enough to do a podcast. So congrats to you that I was able to do it today, because my schedule is so nuts. Usually I'm traveling all over the country, but you got me at a good time. So I'm just glad to spend that time with you. Thank you so much.
Tom, I did a lot of praying. So obviously my prayers were answered. For those who may not have hopped on the last time, can you just tell us a little bit about who you are?
Yep. So I am Tom Viola. I have been a pharmacist for years and years now, almost a little over 30 years. I've been speaking on pharmacology to dental professionals since 2001. I've been teaching a little longer than that. And I've been serving as an expert witness in criminal and civil litigation for about 15 years now. So I have a wide swath that I'm able to stick my feet into when it comes to dentistry, both from the legal side and from the clinical side, as well as daily practice. So I serve as a consultant, speaker. I do just about everything in dentistry that I want to do, except actual hands-on dentistry, because I'm not licensed to. But who knows? Maybe someday someone will let me fool around and I'll see if I can do an extraction or two. Hopefully not. That would be probably not. But the greatest joy is that I'm able to spend this time with dental professionals. I love the whole team. I work well with dentists. I've been teaching hygienists and assistants for years, teaching dentists for years. So it's great to see the impact you have on a patient's career, from their education through their early years as a clinician and then on as they come back to attend my continuing education courses. So yeah, I do love it.
That is awesome. What some may know, but others will discover, is you have this unique knack of educating us and entertaining us at the same time.
Oh, thank you.
I'll go back to when you came to Jamaica virtually. 9 o'clock in the morning, pharmacology. Who does that? But you kept us engaged for the entire time.
It's a lot of fun. Hopefully I'll actually make it to Jamaican soil one day. I'll put my 2 feet in the sand and see. Hopefully it's coming. We'll see.
We have to be more deliberate about making that happen. What do you say?
All right, we'll see what we can do. Sounds good.
So what I'm going to stretch you a little bit with today is talking about opioids. Now, that's a category of drugs that's in the news quite a bit these days, and sometimes not for the best of reasons. So, Tom, what are opioids? How are they used in dentistry?
So opioids have a long record of use in medicine, even going beyond just what we consider to be traditional medicine these days. It's been, centuries and even longer, depending on what recorded history you're looking at. But the bottom line is, in modern traditional medicine, opioids have been used with success and with great failure, depending on how you look at it. As a pharmacist back in the 80s and 90s and the 2000s, until I started to step away and did more of what I do now, I was there. I was one of the pharmacists in the middle of everything in New York City when we started using opioids pretty regularly. And I remember the day when it came down that we were going to be using controlled release opioids like OxyContin. to treat what was considered to be more likely, short-term pain versus long-term pain, more acute pain versus chronic pain. And I think that was the beginning of the end. Opioids are really derived from opium, right? The resin of the poppy plant. Again, we've done a lot with opioids over the course of all these years, from smoking it to making it into, all sorts of different medicaments, and finally, ultimately, to make them into prescription medications. One of the benefits, I think, of opioids is the fact that we've learned to combine them with other ingredients. For example, one of my things I like to talk about in my lectures is the fact that we consistently combine, let's say, oxycodone or hydrocodone or even codeine with acetaminophen. And a lot of people have asked me over the course of time, why would we do that anyway? What is the point? And the answer is, by combining the agents, we get a synergy that allows us to use less opioid to treat the same amount of pain. And some people have said that, the same amount of pain could be resolved with 15 milligrams of oxycodone or 5 milligrams of oxycodone along with acetaminophen 300 milligrams. So that's one good thing we've done. But I think if you had to ask me ultimately, Heather Dawn, what opioids do these days when it comes to medicine, I'd have to say that we are continuing to use them for treating chronic pain, intractable pain, that sort of thing. But you don't see that in dentistry. I think one of the things I make a hallmark of my lectures, which all people bring with them afterwards, is I believe that in dentistry we use opioids more to treat fear than to treat pain.
That's interesting. More to treat fear than pain. So which dental procedures are opioids typically prescribed for? So I want to wrap my head around that belief of yours, treating fear versus pain.
I think it has to do with the procedure, certainly, but I also think it has to do with the clinician and who's the prescriber. We do amazing things with ibuprofen and acetaminophen. One of the things I make a habit of talking about in my lectures is that there have been several studies, even recently, one as early as February of 2025, that have indicated that the combination of ibuprofen and acetaminophen work better than any opioid could in treating pain. And I think, if you think about it, dental pain is acute inflammatory pain. The best way to treat it is with an anti-inflammatory. Well, there's nothing anti-inflammatory about oxycodone or hydrocodone, and there's nothing anti-inflammatory about acetaminophen. So why would that work to treat pain? And the answer is it doesn't. So my belief is that while we call them analgesics and we call them pain relievers, and they do treat pain, I think they're better prescribed. I think they're more prescribed for their placebo effect in treating fear. Because more fear equals more pain, which equals more fear, which equals more pain. But the converse of that is also true. The better I address fear, the better I address pain. So less fear, less pain, less fear, less pain. And what I noticed as a pharmacist all these years ago was that many times people got the prescription from their dentist for the opioid and never filled it. They would drop it off. They would say, well, I'll let you know if I need it or I want it. And it always perplexed me because I thought to myself, well, what would that be doing for them? But then I realized it was indeed that. It was the placebo effect, meaning I didn't necessarily need the pills. I just needed to know I had the script so that it was always there in case I needed it. And so it was that psychological effect, that placebo effect, that gave opioids their justification in a way. And I always felt that's probably the best of both worlds, because opioid prescriptions that never get filled never count towards the opioid crisis or the opioid epidemic, as we call it now. But I could see how some people might look at that as, yeah, well, what about the times they do fill the script and then those scripts end up in medicine cabinets and they end up in the wrong people's hands? Granted. And that's why I think it's up to the clinician ultimately to make the determination as to whether or not to prescribe for a particular patient. I'm not of the opinion that dentists or medical doctors need to be told how to prescribe or what to prescribe or who to prescribe for, because that's their privilege. They earn those prescribing privileges. It's their right to do whatever they want within reason and with good, obviously with appropriate care. But at the same time, while no one should tell them how to prescribe, I think modern day clinicians know when to prescribe and when not to prescribe. And my job is not to tell them how, but tell them, well, here's an opportunity for you. Here's a situation where maybe it's best you did not.
Yes. Well, there are a couple of things that I'll take from what you just said. Number one, I have maybe I could count on one hand the amount of times I've prescribed opioids. I've been able to manage pain very comfortably with ibuprofen primarily. And I often wonder what we say to the patients when we prescribe opioids if they don't fill the prescription and use all the medication. Because I think that we have maybe not an epidemic portion, but it's significant now that we have a lot of young people trying out opioids, and it's easy access. Just open the medicine cabinet.
Yeah.
Would you say that you experienced hearing something similar to that?
I can't say that I've seen a lot lately as I saw maybe 10 years ago. I think the public is much better educated now than they ever were. Again, I'm actually seeing an increase in those times when dentists don't prescribe opioids at all. And that's fine. I think, some that do, it's rare, as in your case, you can count on one or two hands how many times you've done it within a recent amount of time. I think that's because, and I hate to use the words, but the best way to describe it, as I say, is size the patient up. As in, take a look at them and let them know, are they the kind that has a good tolerance for pain? Then maybe they probably don't need it. But, if are they the kind that really don't have a tolerance for pain, then maybe they may require. But even then, I would, if I were the prescriber, I would say, look, I'm going to write you the script, but I don't suggest you fill it unless you absolutely need it. Keep it on hand in case you need it, but don't bring it to the pharmacy unless you absolutely need it. And I think just that alone is enough to make the patient say, wow, this must be pretty strong if the doc says don't fill it, only when I absolutely need it. And I think that's the implied value. I think that's the implied, responsibility now you've given to the patient, as in, hey, if the doc says I shouldn't fill this, I probably shouldn't do it. But notice what that also does. It says to the patient, this must be pretty strong. So look, I have a way out. I have an exit strategy. If the pain gets really bad, I'll just drop the script off. But I better hold off because, doc said I have to hold off, so I will. And I think it's the words you use. One of the stories I tell my audiences is the time when I had my third molars extracted, 16 and 17 extracted. And I went to the oral surgeon and I got all wrapped up and I'm walking out. And the person at the front desk said, here, I've got these prescriptions for you. One's for ibuprofen and one's for an acetaminophen, and the other one is for an opioid. But, to be honest, you could try the ibuprofen and acetaminophen, but, if you need the opioid, don't feel afraid to take it. And what I got from that exchange as a layperson, if I was using my layperson side of my brain, is I guess I better take the opioid because it sounds like the ibuprofen and acetaminophen aren't going to do the job. And I've heard those things before and use those for headaches and backaches. You don't use those for this kind of pain. But would everything be the same? Everything the same, Heather Dawn, if she had just said instead, hey, I've got these prescriptions for you. One is for ibuprofen and one is for acetaminophen. And, we've treated hundreds, if not thousands of patients with this combination. It worked really well. You should be fine. But the doc gave you this other prescription for this opioid just in case you absolutely need it, but we don't recommend you fill it. Just keep it just in case. Now I walk away from that exchange with, wow, I guess this ibuprofen and acetaminophen stuff really works. I don't think I'll ever need this opioid. And in some cases, maybe if you've sized that patient up, as the words I use, you may never even write the script for the opioid, because if you feel they have a strong tolerance for pain, maybe you don't think they need it. But there's only one person on the planet that knows for sure if that patient needs an opioid, and that's the prescriber. That's why it's best left in their hands.
Yes, I get that. And, I agree with you 110%. I have just used that combination with the acetaminophen and the ibuprofen for years, and they have not had breakaway pain. I don't know if things have just been, the gods have been on my side or what, but yes, I do like the way you've couched it so people understand that this is the routine, but here's something in the event that. So what's the standard dosage for opioids for dental procedures, Tom?
Most of the time, it depends on the prescriber's preference. To be fair, codeine is a prodrug. It's not actually a drug that works on its own. It's converted in the liver to small amounts of morphine, and that's how it does its job. And I've seen codeine used primarily as a placebo more than anything, because again, it breaks down at such a small amount of morphine. it's almost as if the acetaminophen is doing the job more than the codeine is. Beyond that, I've seen either hydrocodone or oxycodone used to treat dental pain. And the typical dosage is 5 milligrams of hydrocodone and 300 milligrams of acetaminophen. Same for oxycodone, 5 milligrams of oxycodone and 300 milligrams of acetaminophen. But I've seen higher doses of hydrocodone combined with acetaminophen. I've seen 10 milligrams combined with 325. You don't really see higher doses of Percocet used in dentistry because there's really no need. If your pain is that severe, then especially after a couple of days, I'm going to want to see you again, find out what else is going on. So with those doses, typically I'm seeing a day, 2 days max. 6 tablets, 10 maximum. We're not talking about a lot of tablets here. And I think what I've seen many clinicians prescribe is 1 tablet, no more than 2 or 3 times a day, as needed for severe pain only. And so those are the doses that you see most commonly prescribed. Anything beyond those doses is either very advanced pain, like maybe after some significant oral surgery, or perhaps outside of the realm of dentistry altogether. And that's typically how I will spot prescriptions that just don't belong, if you know what I mean. Looking back retrospectively as to who's prescribing what.
I have a story many, many years ago. I practiced in Maryland and had done a third molar extraction on a patient, and she was allergic to everything except.
Of course.
I prescribed that drug, and within a day, the story came back that the pills were beside the sink and she accidentally knocked them over and she needed a prescription. And I said, well, we can jump down to some ibuprofen. We can rank up the dosage and put some acetaminophen in there, but I won't be able to give you another prescription for that. And she left looking a little deflated, but I was quite comfortable with my decision.
Oh yeah, lots of stories. Lots of stories.
Yes. So, Tom, what would you say are best practices for disposing of unused opioids?
Oh, that's a good question because it really has boiled down to almost what municipality you live in. And it's changed several times over the course of time. So I will give you all of the answers I've heard. But I think for audience members, they're going to need to check with their local municipality to see, what's the best way to dispose of them. So there are still some municipalities that say it's okay to flush them. I'm not a big fan. I don't think that's the best way to do it. Some have said mix them with coffee grounds or cat litter, and crush them up, mix them with coffee grounds, cat litter, and put them in the landfill.
Right.
Again, but the way water penetrates landfills, again, I'm not sure I like that either. I think the best way to dispose of them is to take advantage of the DEA take-back days, where they will set up, sometimes in pharmacies, sometimes in certain locations throughout town, and there'll be a day, I think it's 2 days a year, where you can bring all your opioids there and just dispose of them that way. Now, what they do with them, I'm not sure, because again, it depends on the municipality, but I think that's probably the safest way. The only glitch I see with that is you have to hold on to them till the day comes up.
Yeah.
So again, I'm not a big fan of that either. My thing, and you can't bring them back to the pharmacy because they have no mechanism for disposing of them. And the fact is that once they've dispensed them, they can't take them back. But as is with any medication.
Right.
So the best thing to do, I believe, is not fill them in the first place. And if you do fill them, because here's the thing, Heather Dunn, as we just said, you don't have to fill the script. You have it. Right? So if you don't need it, don't fill it. But if you do need it and you do fill it, then I think the best thing to do is call your local municipality, find out the best way to dispose of them, and dispose of them as soon as possible. For the take-back days, if it just so happens that you happen to have some that you haven't disposed of yet within recent history and the take-back days coming up, then go ahead and utilize that. But I think getting them out of the house as quickly as possible, in my mind, is the best way to go. Yeah.
Mm-hmm. I have a final question for you, Tom.
Yeah.
How best should dental teams educate patients about opioid risks?
Heather Dunn, it's a great question because we have so little time. You've got a half hour, in some cases 45 minutes, sometimes an hour for an appointment. It depends, right? Dentistry is so fast-paced and high pressure that sometimes those conversations don't happen because we're almost afraid of where the conversation is going to go and how long it's going to take. So it's easier sometimes to avoid the topic altogether than to bring it up. But I think a couple of salient bullet points are necessary in any time an opioid is going to be dispensed. And that is, be on the lookout for signs of, difficulty breathing, because respiratory depression is a side effect of opioids. And of course, be on the lookout for minor side effects like constipation, right? Sometimes within one day. And be on the lookout for skin reactions, because opioids can cause reactions that can make you itchy. That's not necessarily an allergy. It's a hypersensitivity, but not necessarily an allergy. A full-blown allergy that would involve anaphylaxis and nausea and vomiting, certainly. So I'd warn them about adverse effects, but I'd also get into the realm of if you take these too long, there's always the possibility of addiction, and resistance is great. So meaning, the more opioid you take, the more opioid you need to take.
Right.
And you develop tolerance so easily.
Yes.
That it's so, even within a few days, it's easier to take more because you're not getting the same effect you were getting previously. Right. So I warn patients about that. It's a slippery slope. You take only what you need and not more. And if you can grin and bear it, the opioid is there not to eliminate pain. It's to make it tolerable. Mm-hmm. You've got to do your part too. I tell patients all the time, and I think we need to tell our patients this as well. Opioids are not there to completely eliminate pain. Opioids are there to be able to make pain tolerable. You've got to do your part. You've got to be able to withstand some pain and just rely on the opioid to take most of the edge off, but not all of it. If you're expecting to get complete pain relief from an opioid, then you're going to set yourself up to take more and more than you should, because you're chasing something that's unattainable. So use the ibuprofen and acetaminophen. That's the first thing I say to patients. Get home, take the ibuprofen and acetaminophen as quickly as possible. As a matter of fact, I've actually asked dentists if they would consider giving the patient a dose of ibuprofen and acetaminophen either at the end of the procedure or even before the procedure starts, to either pre-dose or after dose.
I routinely.
See?
I do that routinely.
Absolutely.
Makes a big difference.
Makes a big difference. So by the time they get home, they get settled in, maybe they take a dose of the opioid, maybe they don't, they see how it is. Then they're ready for their next dose of ibuprofen and acetaminophen, and they're all on their way to getting beyond the window where they would need the opioid in the first place. And I'm not opposed to using, let's say, bupivacaine, a small amount of bupivacaine after the procedure to keep them numb longer so they don't need that pain, right? And I'm not opposed to even giving them an ice pack, even though you don't think there's any swelling. The ice pack does have that placebo effect that you're doing something, right? You're providing your brain with another stimulus besides pain. Yes. The problem headed on with dental pain is that it's where it's located. It's here. It's literally and figuratively in your head. So it's hard to ignore it and easy to obsess over.
I think we've covered so much in such a short period of time. But the information that we've covered, people can grab and use immediately. And Tom, you just have such a wonderful way of doing that for us every single time. We so appreciate it.
Thank you much.
I'm going to spring something at you. I have 3 questions that I'm just going to answer, and I want you to just rapid fire. You ready for me?
I'm ready. Let's do it.
Favorite food?
My favorite food is pasta because I am Italian. So I have to have pasta. Pasta with everything. That's what I say.
Place you want to visit on your bucket list?
Jamaica. That's first on the list. Let's go. What are we waiting for?
These questions are way too easy. All right. There's one thing that you wish you had done that you've never done.
Oh, be a dentist or a hygienist. Yeah. Oh, yeah. I knowing all I know now, I'm like, why did I waste all those years as a pharmacist? I could have been a dentist, a hygienist, and been loving life, helping people, saving people's lives every day. I mean, I'm not knocking pharmacy. We save lives in a way, but I'd much rather do it hands-on. So yeah, that's my one regret. Absolutely.
As my grandmother would say, it's never too late.
They say. That's what they say.
Tom, I can't thank you enough. Every time you come on and you share with us, I feel so blessed because you take the complex and make it simple and practical.
Thank you.
And the best thing that you could ever do for us is to give us things that we can grab and go. Because
yes.
That's what we have time for, to take a little piece and say, okay, I can use that. And you always do that for us.
Well, let me say this. Let me say this, Heather Dawn. Don't thank me too much because a lot of what I know, I learned from dental professionals. So let's give the credit to them because they've taught me as much as I've taught them.
Well, let's keep it going. Thank you.
Yes, absolutely.
That's symbiotic effect.
Yeah.
Tom, question.
Yeah.
Can we count on you to come and visit us another time?
I love this podcast. Absolutely. Because it celebrates the whole team. What's not to love? I think this is great. Yes, let's do it.
Awesome. Thank you so much.
Thank you. Appreciate you.
Well, there you have it. Tom Viola always brings his best. And he was so practical yet informative today. We know that this opioid medication comes from the poppy plant. It's simple as it looks. It packs a powerful punch. And what about the fact that acetaminophen and ibuprofen, that combination, works very, very well for dental pain, which is usually short and inflammatory, right? So examples of the acetaminophen are like Tylenol or Panadol, depending on where in the world you are. And ibuprofen, the low strength brand name that is quite popular is Advil. So the combination of ibuprofen and acetaminophen can go a long way and handle the majority of dental pain. We know that there are issues as to disposing of opioids. Some municipalities say flush them, others say brown them with coffee, bury them. The problem is these potent drugs, if they get into our waters, they can be quite damaging to us as humans. Now, what are some warning signs that Tom asked us to watch out for if our patients had any symptoms like respiratory problems, difficulty breathing? Sometimes they can have skin rashes, nausea, vomiting, constipation, and we do not want our patients to be on any long-term dosage of opioids, because the more you take, the more you need. It is very easy to get addicted to these drugs. So that's it. That's the wrap. Remember, life is better when we live, learn, and grow together. See you the next time.